Okay, guys, sorry. This is just a continuation from the part one heart recording. The largest structures in the heart are the four chambers, okay? And we're going to have two atria, two ventricles. The ventricles are larger than the atria, and they have much thicker walls. The atria, although they do pump blood, most of the movement of blood from the atria is actually due to pressure opening up the valves and just gravity pulling the flow of blood down. In reality, when the atria pump or contract, they're only moving about 20% of the blood. 80% is actually moving passively. Now with the ventricles, this is the actual pump. And the ventricles are much stronger pumps. They have much thicker muscle, and greater strength is needed to generate the pressure that will pump the blood around the pulmonary and systemic circuits. Not as much in the pulmonary circuit as the systemic circuit, but you still need pressure to do that loop. So the atria, these are not symmetrical in size, shape, or location. The right atrium is larger. It's a thinner walled and more anterior than the left atrium. The left atrium is a thicker walled, somewhat smaller, and located mostly on the posterior side of the heart, and makes up much of the heart's base, the posterior surface. Externally, each atrium has a muscular pouch or auricle, named for the resemblance to the external ear. This will expand to give the atrium more space to hold blood. The auricle on the right atrium is much larger than that of the left atrium. You will also have what we call pectinate muscles. These are muscular ridges on the anterior side of the internal surface of the right atrium. The left atrium is mostly formed by pulmonary veins, and internally its walls are pretty smooth. There's an interatrial septum, which separates the two atria. It's a wall. And then there's what we refer to as the fossa ovalis. This is a small indentation in the septum. It's a remnant of a hole, the foramen ovale, in the interatrial septum of the fetal heart. This is a hole that allowed for blood to bypass the pulmonary circuit and go right into systemic circuit. And the reason for this is that during fetal development, the fetus is not breathing, so there is no pulmonary circuit, so you're bypassing it at that point. The ventricles, like the atria, the ventricles are asymmetrical. The right ventricle is wider and thinner with the walls than the left ventricle because the pressure differences in the pulmonary and systemic circuit. The right ventricle has little resistance against which to pump. The left ventricle will pump against a much greater resistance. The left ventricle has to work harder than the right ventricle. Therefore, when you look at the muscle, you will see that it is much, much thicker. It's actually about 3 times the thickness. And here we can see, this is the left ventricle wall here. You can see it's much thicker than the right ventricle wall right there. Internally, both ventricles have a ridged surface created by irregular protrusions of cardiac muscle tissue referred to as trabecula carneae. Each ventricle also contains finger-like projections of muscle referred to as papillary muscles, which will attach by a tendon-like cords referred to as chordae tendineae to the valves between the atria and the ventricles. The intraventricular septum, this is a thick muscular wall that separates the right and left ventricles, contracts with the rest of the ventricular muscle, and helps to expel blood into the pulmonary trunk and the aorta. And if we look here, we can see this is the right atrium here. You can see this superior and inferior vena cava. This is the remnant of the fossa ovalis right there. Here you can see we have our tricuspid valve, which is going to be the valve between the right atrium and right ventricle. Here's the right ventricle. This is the pulmonary valve, which is going to separate the pulmonary arteries from the right ventricle. On the left side, here's our left atria, bicuspid valve, and then the aortic valve. All right, and here you can see, looking at some of these images, right atrium, right ventricle, left ventricle, left atrium. So blood flow through the heart must occur in only one direction, so that deoxygenated blood goes to the pulmonary circuit and oxygenated blood goes to the systemic circuit. Two types of valves prevent blood flow from flowing backward. No valves are needed between the atria and the veins that drain blood into them. Backflow of blood is generally does not occur in the veins draining into the atria because there's really no pressure pushing that blood back in that direction. The atria are under very low pressure. Blood mostly flows into the atria with the help of gravity and the pressure within the veins. Forceful ventricular contractions could drive blood backward into the atria. Now, to prevent this, we have those atrial ventricular valves. And there are two atrial ventricular valves, the tricuspid valve, which is between the right atria and the right ventricle, and the bicuspid valve, or referred to as the mitral valve, is between the left atria and the left ventricle. The chordae tendineae, this is a fibrous tendon-like structure attached to the inferior end of each cusp. It's attached to the papillary muscles that contract just before the ventricles begin ejecting blood. Creates tension on the chordae tendineae, keeping the valves closed. The backflow of blood into the ventricles from the pulmonary artery and the aorta can also occur. Blood flows backward when the ventricles relax as a result of higher pressure in the arteries and gravity. The semilunar valves will help to prevent this. The semilunar refers to the half-moon shaped of the three cusps. It's also composed of endocardium and central collagenous core. They are named accordingly to artery in which they reside. So the pulmonary valve is between the right and left pulmonary trunk. Between the right ventricle and the pulmonary trunk. The aortic valve is posterior to the pulmonary between the left ventricle and the aorta. And here we can see our four valves looking at a cross-section of the heart. And here you can see a valve that's closed versus a valve that is opened. And what happens is the pressure becoming in this direction here, but if you force the pressure in this direction, it would end up closing the valves. It's like a one-way door. Okay, so the big picture of blood flow through the heart. Blood in the systemic capillaries delivers oxygen to the body cells. The systemic veins will return deoxygenated blood to the right atrium. Blood passes from the right atrium through the tricuspid valve into the right ventricle. The right ventricle then pumps blood through the pulmonary valve to the pulmonary trunk. The pulmonary trunk delivers blood to the pulmonary capillaries in the right and left lungs, and this is your pulmonary circuit. The aorta will then deliver blood to the systemic capillaries. So coming from the pulmonary circuit, the blood you're starting back on this side, guys. The blood becomes oxygenated in the pulmonary capillaries, and the pulmonary veins return oxygenated blood back to the left atrium. Blood passes from the left atrium into the mitral valve, which is also the bicuspid valve, to the left ventricle. The left ventricle pumps blood through the aortic valve to the aorta, and then finally the aorta will deliver blood into the systemic capillaries, and the cycle continues all over again. Now, there are some diseases that are associated with the valves. Valvular heart disease can impair function of one or more valves. This may be congenital, present at birth, or acquired from disease process, such as an infection, cancer, or disorders of the immune system. There are two major types of valvular defects: insufficiency, where the valve fails to close fully and allows blood to leak backward, or stenosis. A stenoic valve is when you have calcium deposits in the cusp, makes them hard and inflexible, blood flow through the stenotic valve with difficulty. Often the heart has to pump harder to eject blood through it. Both types of valvular heart disease may cause a heart murmur. This is an audible, if you're listening, swooshing of blood when the heart beats. Other signs and symptoms vary with the type and severity of the disease and may include an enlargement of the heart, fatigue, dizziness, and heart palpitations. The mitral and aortic valves are most commonly affected by valvular heart disease. Okay. The next topic we're going to talk about is referred to as coronary circulation. The heart chambers are filled with blood. However, the blood that's flowing through the heart chambers cannot be used for the heart itself, and primarily due to the thickness of the myocardium. For this reason, the heart is supplied by a set of blood vessels collectively referred to as coronary circulation. The coronary arteries are going to essentially come off of the ascending aorta. This is the main systemic artery into which the left ventricle pumps blood. Immediately after the ascending aorta emerges from the left ventricle, two branches, the right and left coronary arteries, arise and travel in right and left atrioventricular sulci, respectively. The right coronary artery travels inferiorly and laterally along the right atrioventricular sulcus, gives off several branches that will supply the right atrium and ventricle. Okay, and then you have some branches from there. I don't just know the right and left coronary arteries there. Shortly after the left coronary artery emerges from the aorta, it generally branches into two vessels as well, which are going to supply the left side. Okay, the circumflex artery, this curves along the left atrioventricular sulcus and flexes around the heart. This supplies the left atrium part to the left ventricle. In some people, it replaces the right coronary artery and supplying branch to become the posterior interventricular artery. Coronary artery supply is complicated by the formation of anastomosis. This is a system of channels formed between blood vessels. Coronary arteries may form anastomosis one another, with branches from the pericardium or even with arteries from outside the coronary circulation entirely. When blood flow to the myocardium is insufficient, occasionally a new anastomosis will form to provide alternate routes of blood flow. Collaterals help protect muscle cells from damage that could result from a blocked vessel. And here we can see the areas that are supplied by the various major arteries of the coronary circulation there. Now with your coronary veins, majority of the heart's veins will empty into a large venous structure on the posterior of the heart referred to as the coronary sinus, which receives blood from the great cardiac vein, small cardiac vein, and middle cardiac vein. I didn't get very creative with those names. But the coronary sinus is pretty much going to drain blood from all aspects of the heart. And what happens is the coronary sinus will then deliver that blood back into the right atrium, where it can then go through, normal circuit back into the blood. The buildup of fatty material, referred to as plaques in the coronary arteries, results in coronary artery disease. This is the leading cause of death worldwide. Coronary artery disease decreases blood flow to the myocardium, results in inadequate oxygenation of the myocardium, referred to as a myocardial ischemia. When present, symptoms generally come in the form of chest pain, referred to as angina. The most dangerous potential consequence of coronary artery disease is a myocardial infarct, or more commonly referred to as a heart attack. MIs occur when plaques in the coronary arteries rupture and a clot forms. This obstructs blood flow to the myocardium. The myocardial tissue supplied by the artery infarct die, and you tend to lose that functional muscle, which could affect the overall functionality of the heart. Some of these MIs can be fatal, especially if you're affecting the left ventricle. That's the one that usually is referred to as the widowmaker. But some of these, many people survive, in which case, there can be long-term damaging effects of the muscle. Women may not actually present with chest pains. They may suffer back, jaw, or arm pain instead. This is oftentimes referred to as a silent killer for many women. Survival after an MI depends on extent and location of damage. The cardiac muscle cells generally do not undergo mitosis. Dead cells are replaced with fibrous, non-contractile scar tissue. Risk factors for coronary artery disease and MI include smoking, high blood pressure, poorly controlled diabetes, high levels of certain lipids in blood, obesity, age over 40 for males and 50 for females, genetics, and male gender. Coronary artery disease is definitively diagnosed via an angiography. A small tube is fed through an artery in the systemic circuit in ascending aorta and into the coronary arteries. Special dye is injected into the arteries, and their condition is examined by X-ray. Treatments include lifestyle modifications and appropriate medications. If these approaches fail, invasive treatments need to be considered. For example, a coronary angioplasty is commonly performed invasive procedure. The balloon is inflated into the blocked artery. A piece of wire mesh tubing, a stent, may be inserted into the artery to keep it open. The coronary artery bypass grafting, this is more invasive. Other vessels are grafted onto the diseased coronary artery to bypass the blockage and to provide an alternate route for blood flow. Okay, and this is where I would have normally ended the first recording, and I'm actually going to stop here. So the first two recordings are actually really meant to be the first, but unfortunately I had that Zoom meeting I had to attend to that I forgot about. All right, so our next recording will pick up with cardiac muscle tissue anatomy and electrophysiology.